Yes, you welcome everyone to this echo session on this Thursday afternoon. As you know, today we are talking about meningitis in children and adults. And today we have a number of presenters. I am Jacob Busingye, your moderator for today. We shall have a number of presenters who include Professor David Meya, Dr. Juliana Kyaga, Miss Olive Carroll, and one of the guest presenters, Dr. Geofrey Odong, and Dr. Olympia Tombe. We expect to learn a number of things from meningitis, ranging from how to recognize this disease in the children and the adults, but how to investigate it and to plan how to manage, but also some of the skills of how to do a lumbar puncture, how to analyze the CSF analysis that you will have obtained from the lab. And these will be talked about by our different experts, but also from discussion from everyone who will be attending. So we shall start off with a few introductions, the people who are here. One of the case presenters, Dr.
So good afternoon, everyone. I'm Dr. Odong Geofrey. I'm an intern doctor at Mulago National Referral Hospital. I'm glad to be here.
Okay, you're very welcome, Dr. Geofrey. We shall be introducing more of our panelists. Miss Olivia Carroll. Is she online with us? Olympia, sorry. Yes, one of our guest presenters is online. Dr. Olympia Tombe, can you please hear us?
Good afternoon, everyone. My name is Dr. Olympia Tombe. I'm an emergency medicine resident at the University of Botswana. I'll be giving a presentation on adult meningitis approaching the AME.
Yes, thank you so much, Dr. Olympia. Professor Meya, you can go ahead.
Oh, sorry, I just joined. My apologies. What am I supposed to do?
Professor Meya is supposed to introduce yourself to our listeners.
Okay.
Yes.
Okay. Sorry, apologies. I joined a bit late. No, so David Meya, an infectious disease physician based at the College of Health Sciences, Makerere University, and have been doing work with HIV-related meningitis for the last 1.5 decades or so. I'm pleased to be part of this CME. Thanks.
You're very welcome, Professor David Meya. So we shall go on to the pretest. The pretest questions that will be put up, and we shall answer these. Then we shall go into our case presentations. Can we put up the case presentations, please? Okay, so our questions have been posted. Let us try to answer them within the next 5 minutes so that we can smoothly move on to the next part of our session. Thank you. As you answer those questions that we have posted, which we said we shall do in the next 5 minutes, please, you can send some expectations. You expect, like I've told you, what we intend to discuss and talk about. You can send more of the expectations that you would want our panelists to talk about. You can post those, and we shall give a chance to about 3 or 4 people to tell us exactly, to unmute and talk to us about their expectations. Thank you. We have 3 more minutes to do the pre-test. Let's go through it. Yes, let us continue to answer those polls. There are about 4 questions. Let us run through them and we can move on to the next part of the session. Kenneth, you have said that the sound is missing. Are you able to hear us now? Has everyone been able to access and see where the polls, the questions are? If you're having any trouble, you can tell us and we help you. Okay, I see you said that the sound is back. Thank you. Okay, we have added 2 more minutes to complete the polls and then we can move on to our case presentation. And I hope all of you are able to see where the polls and the questions are. Okay, let us keep, I hope we are summarizing the answering of the polls. Please let us go through the polls. I'll be prepared to go to the next part of our session, which will be the case presentation. Okay, so we shall move on to the next part of our session today, which will be a case presentation from Dr. Geofrey Odong, and we shall be putting it up that we can be able to start to present. Let us listen attentively to this case, and then we can have reactions and questions for Dr. Geofrey and all the panelists. Thank you.
Good afternoon, everyone. I'm Geofrey Odong, and I will be taking you through the first part of the presentation about meningitis in children. We have TA, a 5-year-old male, a referral from Okumero Health Center 4 with a diagnosis of cerebral malaria for further management after the third dose of Tunate. With no improvement. He presented with a 2 days history of high-grade fever, intermittent fevers, convulsions, and loss of consciousness. So in our acute care unit, we did emergency assessment and management, where we checked for the airway and the cervical spine. And we noted that the child was not having any noisy breathing, and therefore we did not do any intervention. And in the breathing, it was saturating at 88 to 90% on room air with a respiratory rate of 28%. He had equal bilateral air entry symmetrically. However, we had transmitted sounds. So we initiated him on oxygen therapy by nasal trunk and a low dose, and the saturation increased to 98 to 100% on 2 liters per minute. And in our saturation, we noted that the child was not hypotensive. He had warm extremities with a capillary refill time of 2 seconds. He had a pulse rate of 125. The BP was 102 over 53 millimeter of mercury. Heart sound 1 and 2 were heard, and there were no hearted sound. So we just initiated on we inserted a cannula, which we used to get samples for our investigation. And on the disability, he was asleep, arousable with hyperextended neck in opistotomous position. The AVPU, he was reactive to pain, and the glaucoma scale was of 9 over 15. He had he could open his eyes to pain, and he had inappropriate words, and he could withdraw to pain and on the motor, giving us GCS of 9 over 15. The pupils were anisocoria, of which the right was 3 millimeter and the left was 5 millimeter, and sluggishly reactive to light. The brainstem reflexes were intact, as the gag and the corneal reflexes were intact. And mainly we have the neck was stiff, and he had a Koenig positive, and the Busingye sign was positive. We did a RBS, random blood sugar, and it was at 2 millimole per liter. So we noted that the child was 12 kilograms, so we initiated on IV dextrose 10% at 60 mils bolus. We gave at 5 mils per kg. We initiated inserted NG tube, and later on after the bolus, we gave a maintenance fluid according to the weight of normal saline and D5. We put the patient in a lateral recumbent position. And in our exposure, we noted that the child had no sign of any major trauma or any sign of injury. The patient was febrile to touch with an axillary temperature of 38.8 degrees Celsius. So we exposed the baby. We also did tepid sponging, and we initiated on IV paracetamol 100 milligram TD. So basically, in our signs and symptoms, that was what we did in the emergency assessment and management. And further on, we went to the signs and symptoms, which we noted that the baby had, in the history, had 5 episodes of generalized clonic convulsion, lasting about 3 minutes with associated urine incontinence and reduced level of consciousness post-ictal. He had no bowel incontinence, and it was a bit irritable and was screaming on touch or any stimulation. We noted there was no history of food and drug allergy, and in the past medication, he finished a dose of IV artesunate and paracetamol, and there was not on any long-term medication. And mainly in our past medical history, the child was a referral for further treatment. It was a referral after treatment with no improvement. There was no non-chronic illness, and notably in our past medical history was that the child has had several outpatient visits within the course of the month for upper respiratory tract infections with no improvement. There was not a history of cough, not a history of fever, headache, and malaise and irritability and vomiting. And our last meal, the child, we noted that the child had beans and matoke 12 hours prior to the loss of consciousness and the history of convulsion. So that could explain why we had hypoglycemia. And we noted that the first episodes of the convulsion started at home when the child was seated, noted a sudden fall and jerking movement of the whole body. That's what we got from the caretaker. So in our problem list, we have one history of convulsion. We had the child was hypothermia of 38.8 degrees, and there was noted reduced level of consciousness, and the child was unable to feed, and the history of cough. So, well, our investigation, we did RBS, and he had RBS of 2.0 millimole per liter. The caretaker declined lumbar puncture, so we couldn't do. We did a blood culture. However, there was a mistake during our procedure. The lab reported a gram-positive spore-forming bacteria. However, we were advised to do a second repeat of the blood culture. So we sent sample and we are still waiting for it. And we did MRT, it was positive. However, the BH was negative. There was no malaria parasite seen. We also did a brain CT scan, which showed a multiple patchy leptomeningeal enhancement and severe brain parenchyma, cortical and subcortical white matter hypoattenuation bilaterally with associated moderate increase ICP. And these are I'm sorry, they're not very clear, but that was the brain CT and for lumbar. And we also did an HIV serology, which the child was negative, and the gastric lavage for gene expert, which was negative for miliary TB. We did a CBC, it was moderate anemia of 9.3 grams per deciliter. He had elevated white count of 13.2 with predominantly neutrophils of 10.3. He had a normal platelets health of 287. The CRP, C-reactive protein was normal of 249. And we did a renal function test, which all the values were within the normal range. And in our electrolytes, we noted mainly in the potassium, where we had a slight increase of 5.64. However, the other findings were normal. So our diagnosis was acute bacterial meningitis in view of the history of the upper respiratory tract infections and convulsion and fever. We also thought of viral meningitis and meningoencephalitis. We had thought of tuberculous meningitis. However, we ruled that one out because of the negative gene expert. We also thought of cerebral malaria. Yeah. And mainly in our treatment, the child came in actively convulsing. However, we couldn't assess diazepam by then. So the only available medication by then was IV phenobarbital, which we initiated on 100 milligram start. Then we maintained at 60 milligram OD. The child is 12 kilograms, so we initiated at 15 mils per kg and the start and the main. We also initiated on IV sex reaction, 1.2 gram OD and IV metronidazole. However, after 2 days, there was no improvement and the child was still spiking fever. We later switched to meropenem, 480 milligram, 8 hourly, and IV gentamicin OD for 14 days. And after that, we noted progress improvement. We also had a cycle of in vivo because we couldn't do the lumbar puncture, so we couldn't rule out the possibility of viral meningitis. And with the history of raised intracranial pressure, we initiated on acetazolamide, and because of the fever, we gave the child IV paracetamol, and we inserted an NG tube for feedings, which is started on 200 mils 3 hourly. We also initiated on urethral catheter. So mainly in our follow-up, we noted that patient was in ward. It's 10 days in ward, and came in unconscious with the GCS, and the GCS markedly improved. He was responsive verbally, however, he was not alert by then. His eye movement was spontaneous, and the verbal was still a bit confused. So we gave a 4, and in the motor he could localize the pain. So we had an improvement of 11/15 in the GCS. The pupil were equal and reactive to light at 4 millimeter in diameter. Mechanics was still positive. However, there was no noted cranial nerve palsy, and the reflexes were equivocal. We were not on obvious respiratory distress, so we actually weaned the baby off oxygen. So this morning, the child was not, the screaming had stopped, the child was calm, and the baby was fever-free for 3 days. However, he was still unable to sit in bed, and the patient is still under our care and for review by the physiotherapists and ophthalmologists and probably the ENT. Thank you very much.
Okay, thank you very much, Dr. Geofrey, for that case presentation. It was a very thorough explanation of how you managed for the patient over the number of days. At this point, we shall welcome any reactions to this case. These involve seeking clarity from Geofrey for this case, how they managed it and how the child is. So we welcome any questions. I see one of the questions for Martin Tumwebaze. He would want to find out what the weight of this child was.
The child was 12 kilograms and was also 12 years old.
Okay, so Tumwebaze, Martin, the child had...
No, actually 5. I mean the child is 5 years old and the weight is 12 kilograms. Okay. I think I saw some mistake somewhere in the charts there. 5 years old and the weight is 12 kilograms.
Okay, so the child had 12 kilograms, and it's noted it's a very small weight for his age. Yes, thank you. Any other reactions? We also have Dr. Dickson Kamoga online, who will be our expert on online. He will be helping us answer some of the questions that will come up. So please keep looking at the chat. Dr. Dickson Kamoga will be answering those questions. Any other concerns about this case? Okay, Kevin in Suga is asking, what was the self-reaction that we gave? Was it given according to the meningitic dose? Also wants to know why we chose metronidazole and the safety of acetazolamide. So he's asking about the treatment, the antimicrobial therapy that we gave. Was it the self-reaction? First of all, was it according to the meningitic dose? Yes.
Well, early on, like in the acute, we, based on the history, the brief history we took, because it was an emergency, the brief history we took was, we thought of maybe, because the baby was, the mother presented that he had history of, was being treated for malaria. So we never went that far to think maybe it could be a case of meningitis. So we didn't actually initiate on the meningitic dose for the IV safe reaction. The dose for the acetazolamide, we basing on the increased ICP, we decided to initiate on the IV acetazolamide.
Okay.
Yeah. And there was a question about
Why metronidazole?
Oh, we wanted to cover for the gram negative.
Okay.
That may be.
Okay, thank you so much.
However, based on our negative BS and the report, we had to do further investigation to rule out malaria completely.
Okay. Yeah. Okay. So there are more questions still about the pharmacotherapy. Price would want to know why we gave the child a cyclover, but Dr. Geofrey hinted at it was he was presenting that the results of the lumbar puncture were not very definitive to rule out if there was a viral cause of the meningitis. So the team that was taking care of the child thought it wise to add a cyclover to the management of this child. Yes, I see most of the questions are rotating about the pharmacotherapy. Any other questions that we can have before we go on to the discussion of the case with Dr. Juliana?
Why not given steroid? Well, in our setting, we didn't give the steroid one. The studies that okay, for me, I thought that like in the studies we have the steroids are okay. Well, they have no specific benefit. In the study I got was that there was no specific benefit in reducing mortality and the outcome and the outpatient patient care. However, it would actually would actually make us.
Forgive us for that short mishap in the sound. It was a technical error on our side. I see many of us are really asking many questions about the pharmacotherapy. Why ceftriaxone? If the child was not responding to ceftriaxone, what would you have done? What did you do? Many of them want to understand why acetazolamide. Some of the questions have been answered by Dr. Geofrey, but also want to know why not the steroids? So I think that's the purpose of our rest of our panelists. We are going to talk more on why and when and if really steroids indicated in this meningitis treatment in these children, but also as we shall see later in the adults. So let us just keep some of those questions coming. In the next 1 minute, we shall be starting the presentation from Dr. Juliana, and as we discuss about how to well approach this patient, this child with meningitis. Dr. Juliana, you're welcome. Yes. Okay, as we are setting up the presentation for Dr. Juliana, I see some of these questions keep coming. Many people are asking why we did not give, why the patient was not given meropenem. So most of these questions are going to be answered as we discuss this patient further with the experts that are on today. I hope our sound is quite clear now, because I keep seeing in the chat that the sound is not very clear. Is it clear for most of us? Okay. So most of them, yes, really, I see the questions keep coming. Agostino is asking, why not shift from ceftriaxone to cefotaxime other than meropenem? So all these questions about the pharmacotherapy, the plan of how we can treat meningitis in these children, and in particular, this particular patient who presented to the team after being treated for severe malaria and they were not improving, and why they took the direction they took. So we have an expert in the room who is going to be able to help us answer some of these questions with the discussion. Yes, and some of us are also concerned about the weight of the child given his age. We said that this child had 12 kilograms and was a 5-year-old. Many of us are asking about, did we measure the mark of this patient? Did we assess this child for malnutrition? I think I'll put that question to you, Dr. Geofrey.
Yes, well, okay, well, the child is malnourished. Yeah, we in fact wanted to we are planning of taking to a nutritional unit, Namuju. Yeah.
Okay, thank you so much, Dr. Geofrey. So I think that answers most of the questions asking about the malnutrition that this child has. So after the inward patient management, the team that is managing for this child plans to connect this child to the nutrition department to be able to continue this child's management. Okay, thank you so much. As we prepare to have the presentation for Dr. Juliana. Okay, so those are our slides that have been put up for Dr. Juliana Kyaga to be able to discuss for us today and help us enlighten how to have the emergency approach of meningitis in these children. We shall tailor this case also to this discussion, to this case that we're talking about, to help us understand how to manage meningitis. Yes, to better manage meningitis in these children.
You had introduced them.
So you're very welcome, Dr. Juliana. She's a pediatrician from Makerere University. You can please take that floor. You're welcome.
Good afternoon, everyone. Thank you so much for joining in this afternoon. We're so happy and honored to be with you today. I've been introduced, so I'll go straight away. Thank you so much, Dr. Odongo, for sharing this very nice, very interesting case and for managing this client this patient on the wards. So we shall go on. I'm basically going to really discuss the case, sort of discuss emergency approach to meningitis in children, but also while talking about the case, I can't see what's made, but also while talking about the case. And the outline is basically going to include so should I? Yes, so we're going to just define and talk about things like prevalence, etiology, the presentation, yeah, and emergency assessment. So what is meningitis? If you were to take a cross section of the brain, you will see that there are layers that cover the brain parenchyma. And these layers are what we call the meninges. So you have the dura mater that covers the outer layer of the brain, and the arachnoid and pia mater, and the two inner layers, the pia mater and arachnoid, are the ones that we commonly refer to as the leptomeninges. Below those layers, you will find a space, a subarachnoid space that usually contains cerebrospinal fluid. And this is really a watery liquid that cushions the brain from impact, protects the brain, but also nourishes the brain. So when we talk about meningitis, we're basically talking about these layers around the brain and the spinal cord. And we're talking about inflammation or swelling of these thin membranes. It's a serious condition, often life-threatening, and in pediatrics, I think altogether, but most especially in pediatrics, children under 5 are usually the most affected. So if you talk about the causes, like I said, that this is swelling of these membranes that cover the brain, and so it can be from a number of causes. some infectious and others non-infectious. By and large, you will find that meningitis is generally caused by infections, and this will represent that maybe 99% of the meningitis that you will come across. And these infections may be bacteria, there may be viruses, there may be other organisms. So with our client, we were thinking that this client had an acute bacterial meningitis. And when you talk about acute bacterial meningitis, still there are about 4 organisms that will be responsible for more than 50% of actually more than 80% of acute bacterial meningitis that you will get. And these are Streptococcus pneumonia, these are Haemophilus influenza, Neisseria meningitidis. Those top 3 actually are the most common. But if you look at other populations, younger populations, especially infants and neonates, then you will see other organisms like gram-negative bacilli, E. coli, Klebsiella. You also have the monocytogens, and then group B Streptococcus. But bacteria, the top 3, I think, as per the slides, those are the organisms that are culprits in most of the meningitis that we will find. And the good news there is that we have vaccines for all these. And because of the vaccination that we have, a lot of these have now become fairly rare, unless there are other risk factors, as we shall talk about later on. When it comes to viruses, we have things like herpes viruses, enteroviruses, things like mumps, so it's important to also always know that there are viruses that can also cause meningitis and keep those in mind. We have other organisms like Cryptococcus neoformis. I know that many of you here must be very familiar with this, especially among adults in HIV. However, this is quite rare in the pediatric population. We also have Mycobacterium TB. This should be under bacteria, but I just separated it because of its unique features. It's also another common cause of meningitis among children. And as you know, even for our child, we were suspecting that this might be a cause. However, we eventually ruled it out. When you look at the incidence of meningitis, this is according to the Uganda National Public Health Institute. They looked at, previous slide, please. They looked at the, yes, when you're right. So they looked at the incidence of acute bacterial meningitis between the years of 2014 and 2018. And this was national data. And they were looking at records that had been reported through the DHIS2. And the main point here is just to see with the blue line talks about those that are under 5, and then the line below it is the children that are above 5 and adults as well. And I think it's just very clear for you to see that the incidence of acute bacterial meningitis among under 5 is much higher, and is much higher, although we've actually seen some improvements in the recent years. So who is at risk? Uganda is one of the countries, 26 countries that lie in the sub-Saharan meningitis belt. This is the African meningitis belt. And this is basically a region that has been found to have high prevalence of meningitis and high likelihood of having epidemics caused by meningitis, especially meningococcal meningitis as well as pneumococcal meningitis. So the districts labeled in orange are the ones that really sit within this belt, and so the prevalence there is high. Because Uganda sits within that belt, generally speaking, we are all at high risk of meningitis. However, children under 5 years, infants and neonates, of course, are at a much higher risk than the rest of the population. People who stay in overcrowded areas, for example, students in boarding schools, people in military camps, in refugee camps, any areas that generally have a lot, even just having mass gatherings, we need mass gatherings for a long time. Yes, so these are at an increased risk because of easy spread of these bugs among these people. Then, of course, you have immune deficiency, people who have HIV, especially in children, but also children that maybe have primary immunodeficiencies. These are also at an increased risk. Then immune suppression for any other cause. So things like malnutrition, which is something that we have to look at for our child. I think people in the audience have already talked about the child being 12 kilos and 5 years. That was extremely small for the, that was extremely small for their age. And so this child was very likely malnourished. Dr. Odongo, I don't know, did you have the nutrition assessment? What was it for? Yes, so we see there was malnutrition in this child. The child had moderate, but was probably going into severe acute malnutrition. Then things like anti-cancers. Then people have been talking about steroids. People who are on steroid therapy can also have immune suppression, and this will predispose them to meningitis. I also wanted to mention cerebral malaria. Studies have shown that almost up to 30% of children that have cerebral malaria, that is actually confirmed cerebral malaria, also have a comorbid bacterial meningitis that goes along with it. And so, for example, if you think about our child who had been treated for malaria and he had a positive RDT, so the malaria was not a lie. However, he had a comorbid acute bacterial meningitis. This is not unusual. Cerebral malaria will lower your immunity and will predispose you to bacterial infections. So children that have cerebral malaria should also be assessed for acute bacterial meningitis because of the increased risk in this population. So carry on, please. So how will they present? Again, I hope this is clear. Again, according to the Uganda National Institute of Public Health Institute, they also released data, national data for children that had been diagnosed with meningitis, and they looked at the symptoms with which they presented. By and large, you will find that nearly almost 100% of these children will have a fever. They will be very weak. They will be lethargic. You will also find that convulsions will be very common. Actually, I would say that most of the times in our setting in hospitals, what will bring them will be convulsions. You see that according to the national data, almost 85% of the children with the meningitis also presented with convulsions. And many times this is the actual presenting complaint when they come to hospital. So they will have reduced altered level of consciousness. Almost 3/4 of them will have some alteration of consciousness, and many of them will even have will actually be comatose. Our child was not comatose, but he had a very low Glasgow Coma scale as well. So neck stiffness. Neck stiffness is also common. I'll just like to make a point there that when you're talking about children, especially those below 1 year, that is infants and neonates, neck stiffness may be absent, and other common signs actually maybe that we'll talk about in the assessment, things like Busingye and Canig sign may be absent. So they may not have the typical features of meningism as we know them, especially in adults. However, your history, your general assessment of this child should still continue to give you a diagnosis of meningitis, even in the absence of these signs. So neck stiffness was still common, but however, you should note that it's not always present, especially for the much younger children. So things like headache, these ones will be reported by older children. Younger children may not report it, but they will have it. And it's also important to remember that even if they're not telling you, most of the times when you see them being really irritable, it's probably because they're in pain and cannot express it. So they had confusion, there was vomiting. Many times we look for projectile vomiting, but in children, this is almost never seen. So vomiting by itself is enough as a sign of meningitis. And then things like confusion, diarrhea. Yeah, so things like diarrhea and cough. So how does cough and diarrhea come in? We talked about the possible causes. When we talk about things like enteroviruses, this child may actually begin with a diarrhea and then eventually come with a meningitis. Things like cough and runny nose should also help you understand. So if you have a runny nose, for instance, before these symptoms, then you think more likely it could be a virus because the viruses were the ones that were causing the runny nose. However, it could still be a bacteria as a superimposed infection. So another symptom I'll talk about is the last one there. You see the skin rash. So the skin rash there is a small percentage, and that's because it's usually caused by one particular bug, and that is meningococcal. Neisseria meningitidis, yeah, so meningococcal meningitis. And this often comes in the later stages where children will have a purplish rash all over their body. It may look like petechiae, if you know what petechiae looks like. However, this is one of the pathognomonic signs of meningococcal meningitis in children. Okay, carry on, please. So when you're talking about the assessment, especially in the emergency setting, I think like we rightly assess our child, really the important things are going to be your ABCs. I hope that the people on this forum, being an EMS forum, are really very conversant with the ABCs. So the airway should be patterned. Do not attempt to put things in the mouth because this child is likely to come in convulsing. So unless you have an airway that you can put in, do not attempt to improvise with other things. However, always ensure that the airway is patterned, then ensure that this child is breathing well. You do have to look at the SpO2 and then give them oxygen therapy as appropriate or as required. Circulation, many times these children that have meningitis will also present with circulatory deficiency, and they may have shock, maybe from sepsis. And so this is something that is also very important for one to look out for. Then disability. So when it comes to disability, being that we're talking about meningitis, maybe I'll expand a little more on this. So the level of consciousness is very important. And of course, in the initial assessment, initial emergency assessment, you may use APPU, but as and when opportunity allows, you can also do the Glasgow Coma Scale and score this patient. It's very important to, many times these children will come in, they'll probably be unresponsive, responsive to pain or verbal response, but the level of consciousness is very important for us to note, and it may also determine how and where you manage this child from. So neck stiffness, I think I have talked about that. The neck may be stiff, and I hope that we are able to do that examination. You need to look at the pupil size. You need to look at the pupils. Are they equal? Are they reactive? Because this may also show you, for example, if you have unequal pupils, you may think that maybe there's something in the brain, like a space-occupying lesion. If you find that equals are too small or they are wide, then you think of things like increased cranial pressure and herniation. So
much static, please.
Which are complications? Yes, so when you look at so again, for meningitis, we would want to look at the Canning sign, and I hope that we know how to do the Canning sign. We lie the patient down on their back, lift their leg up to 90 degrees, and thereafter extend the leg, extend the leg, and usually they will lift because of feeling pain. In children, they will probably just cry or scream, and that will be a positive Canning's. Please remember, I want to emphasize this, for the younger babies, this might not be present, so should not rule out meningitis. Anyway, yes, so.
Doctor, we don't hear you, and yet you have very wonderful information.
You are lost, we are not getting you.
Yes, we had some technical issues on our side. Is it clear to you now?
Hello.
Yes, please.
Yes, it is clear.
You can continue, please, Sarah.
Okay, sorry. I don't know where we lost you from, but we'll share the slides so you can maybe read up later. So I was still talking about assessing disability. So Busingye, you will lie the patient down on their back. You lie the patient down on their back, and you lift their head, and they will automatically lift their legs. They will automatically lift their legs. You can go back and watch YouTube videos on how to assess these two. but these images should give you an idea, and that is still a positive Brzezinski. So you also need to look out for any focal neurological deficits at that point. Maybe if there is weakening, sudden weakening on one side, maybe increased reflexes on one side, that may probably show focal neurological deficit. That is very important because it will also determine some of the investigations that you will do thereafter, or the things that you may decide to stay away from thereafter. Then also look at, their clothes. Is there a history of trauma, especially in children? Is there a history of trauma, accidental or non-accidental, if they have some old scars on them? And then you also need to rule out things like poisoning, which is very common for little children, especially like little boys of 3 years, 4 years. They explore the environment and can easily be taking poisons like organophosphates and present in a pretty similar way, like a child who may have meningitis. So in terms of investigations, so in terms of investigations, if you're to look at this, so you've got your quick history, please go back up. You've got your quick history. You've got your, so you've got your, I don't know if this is clear for you, but you'll be able to see it better maybe when we share. But if you've got your quick history and you suspect a bacterial meningitis, of course, you will look at the ABCs like we have talked about, and the level of consciousness, and you want to initiate your cardiorespiratory monitoring, still as part of monitoring your ABCs and ensuring that this child it does not have any current danger signs that we're not managing. We'll then go on to look at hemodynamic support. We'll want to obtain a venous access, initiate hemodynamic support. Like I said, many times the children will appear. First, they may be dehydrated because they've not had anything to eat for some time due to the illness, or they may be vomiting a lot, and that will also give them dehydration, but they may also be septic and in shock, and you may need to manage this, give them some hemodynamic stability before you actually do any further assessments. You will then want to do a basic initial labs that want to start with, and this is in the emergency room, okay? So you want to look at their electrolytes, you want to look at a complete blood count, and this will help you look at with differentials. This helps you look at whether there are infections or not. You also want to do a blood culture for this child, okay? Now the next thing will be for you to think of a lumbar puncture to look at the CSF. Remember, we said that this infection is affecting the covering around the brain, but also the CSF that washes around it. So the CSF that washes around these meninges can tell us a lot about what is happening there. However, in this algorithm, what I want us to take home from it is that, when you suspect bacterial meningitis, you may need to do a lumbar puncture. However, not every patient can receive a lumbar puncture. So we have our patient, for example, who declined consent. And that is also very important because you have to tell the patient about the procedure that you're going to do, and you should not force this procedure on the patients, okay? However, in the event that you've actually received consent, you also need to consider a few other things. If you think that this patient has increased intracranial pressure, and I will share a few signs later on, then they should not receive a lumbar puncture because it may cause complications such as herniation. If you think that they have a focal deficit, so if you think that maybe this child has meningitis, but there's probably also an abscess because when you were doing your initial assessment, you realized that there were some focal features from your CNS exam, then this child should not receive a lumbar puncture. Additionally, if the child has a CNS lesion that we know of, like a tumor, or if they've had trauma, they've fallen, they've in an accident, border accident, If they have a CNS shunt, for example, a child that is being managed for meningitis, we may want to first hold on regarding the CSF analysis. I mean the lumbar puncture, as well as if they have a coagulopathy, they have some bleeding disorders. If they have some bleeding disorders, and also if they have a hemodynamic instability, for example, if a child is in shock, we should not be doing a lumbar puncture on a child that is in shock. Yeah, so I think let's carry on to the next slide. Just kindly, you may not pay too much attention to the rest of that. Yes, so again, like with investigations, we talked about the bloods that you will need to do. And then I've also talked about the lumbar puncture. But there are also other investigations that you may have to do. Other investigations that you may have to do. We have talked about malaria co-infection. So in a child, especially in our setting that is coming in with fever, vomiting, convulsions, we really need to test for malaria, okay? And many times we may actually even find that it is present. We'll do a brain CT scan, MRI, and this may show different kinds of features, but most importantly, we will find inflammation of the meninges in the brain, but there may also be other localized features that you will find. And then the CSF analysis and CSF culture. So the CSF analysis will give you results. I'm going to just talk about those briefly. And then we also have the CSF culture, which will help to grow any bacteria or mycobacteria that you may suspect having been the cause of the infection. So when it comes to the CSF analysis, we talked about different types of organisms that may cause infection, and this may be, bacterial, viral, fungal. What is important to note is that sometimes, even just as you're doing the lumbar puncture, sometimes on visual assessment, just the appearance, you may be able to tell that you have a bacterial infection, because many times that the CSF will be turbid, okay? It will be thick and turbid. Additionally, when you finally take the samples to the lab, but CSF that has bacteria, that is from a bacterial infection, will have a very high white cell count, commonly more than 500. And then you may be able to see some bacteria on gram stain. Commonly, there will be a low glucose. There will be a low glucose in the CSF. However, a low glucose in the CSF and a high protein. So this kind of chart is very important for you to always have with you to sort of understand after you receive the results. Is this more of bacterial? Is this more of viral? Is this more of fungal? Okay. Viral infections, many times you may have a very normal CSF, or you will have a CSF that has some elevation of white cell count, but not really a lot, okay? And then the fungal also generally looks slightly different, and many times you have increased monocytes, you have increased lymphocytes, especially for TB, meningitis. However, these are not as common as the bacterial meningitis for children, okay? Yeah, let's move on. So so before I move on, about our child. So our child had a CSF that was not very clear, and this could be from a number of reasons. It could be because we had given some treatment to this child by the time we had the CSF. We didn't have CSF. Oh, sorry, we didn't have CSF for our child, yes. But it also happens a lot in hospitals, especially if you work like in a big hospital where children come to you as referrals. So they will come and their CSF might look a bit close to normal, but it's because of treatments that they have received in the past. So it's very important actually that when you're managing a child, get permission to do a lumbar puncture and CSF analysis at admission, the very first time you're seeing this child, so that you're able to get the best, results coming out of it, results that you can make a conclusion on. Yes, so I'll move a bit faster. So Emergency management, I think we've talked about the ABCs, and these are very important. I'll talk again about conversions a little later, and then also the infection. So maybe for infection, I think we've talked about the ABCs. I'll not go so much into those again. But for infection, we talked about IV ceftriaxone is the recommended first line, and that is 100 milligrams per kilogram. Additional antibiotics you may use according to the cultures that you receive. So this is the initial treatment, and many times you want to give it for at least 2 weeks or 21 days if you're suspecting that this was a gram-negative bacteria. So don't give it for just 5 days like we're used to other infections that we treat for a very short time, okay? So people are asking a lot about steroids. So in bacterial meningitis, especially, steroids there's not been any actual evidence. There have been studies that have used steroids and found that maybe it was beneficial, but altogether, through systematic analysis, there was no actual evidence that steroids actually improve the outcomes of treatment in bacterial meningitis. And this is very important to note because steroids also have their own side effects. They can cause further immune suppression. So without actual evidence that they will actually give improvement, it's better to always stay away from steroids. However, if you suspect that the child has TB meningitis and you have other symptoms that support the diagnosis of TB meningitis, then steroids actually do have very good benefit in management of TB meningitis. So we need to make that distinction clear. Yeah. So this is an algorithm. Again, I think we shall share with you, but this is management of conversions. Like I said, most of the times these people are going to come in with conversions. And in our setting, we are most likely going to have our first line as diazepam, and this is rectal diazepam. Of course, if you have IV access, then IV diazepam is better than rectal. However, rectal diazepam at 0.5 milligrams can be given twice. It can be given twice after 15 minutes. If the child is still continuing to convulse, after maybe 10 minutes, the child is continuing to convulse, you can give another rectal diazepam. But after that, then you need to move on to other drugs like IV phenobab and IV phenytoin. And then by this point, you need to be thinking about talking to the people in the ICU. You need to be thinking about having this child referred if you're at a lower center. So this algorithm will be shared with you and you can be able to look it up or chat it up. I think you probably already have one. Yeah, so one of the common complications I'd want to talk about, convulsions is one of the acute complications of meningitis that you need to manage. But there's also another one that sometimes we forget about, and this is increased intracranial pressure. And this is actually also present in our child. So many times you will have a child with tense and bulging fontanelle. Many times they will have separated cranial sutures, so the head will sort of continue to enlarge. They'll be irritable, they have a high-pitched cry, they'll have distant scalp veins, crying when disturbed and setting sun eyes, and sometimes the head is actually enlarging, like head circumference is enlarging day by day, and this is because of increase in the cerebrospinal fluid. But many times also, as when they're older, they'll have more headache, nausea, vomiting, diplopia. So this is a common sign, a common complication, a common acute complication of meningitis that we must always look out for as we manage these children. Again, if you're talking about management, ABCs always at the first line, and you have to make sure that you have sorted this child's airway, they're breathing, their circulation. But it's also important to elevate the head of the bed, and also hyperosmolar therapy. So I think in our child, we're using acetazolamide. You can also use mannitol, you can use hypertonic saline, and all these are really to help reduce, they increase the osmotic gradient and help to reduce the fluid in the brain that bring it more into the circulation, as well as hyperventilation, okay? So these are very important for us to note. Yeah. So I think I'll stop there for now, and maybe we'll hear more from the team at the discussion.
Okay, thank you so much, Dr. Juliana. That was a very elaborate explanation of meningitis in this population. There are a number of questions that you have answered. There are the questions that are being asked as you are presenting. But I just want to direct you just to start at the point that we have stopped at the management. Some people would like to know that this treatment that we are doing for 14 days, we have it all 14, all the 14 days, this is supposed to be IV, Or is there a time when we can change the same class of the drug and we continue them as oral? Or do we finish the 2 weeks as IV treatment?
I answer that, yes. So it's IV treatment, IV treatment. So many times what you have to do is explain to the patients, because many times when you're giving them treatment and they are better, they want to go home, but you explain to them that for this particular illness, you have to stay in hospital so you can receive the full dose of IV treatment.
Okay, I think that is clear. So we have noted that it has to be all those 14 days that we have said on IV treatment. Please emphasize to our patients to explain them the need of having this IV treatment for that long time. It may seem a very long time for them, but it's very important for them to actually have this treatment. You have hit upon the use of steroids. Very many people wanted to understand the use of steroids. It is now very clear that there is no actual benefit. And like she has noted that there are some dangers that may arise from just routinely using the steroids. So please take that as a concern. One of the participants wanted to know, at what point can we do Busingye sign? Do we do it for all the children? Is there a particular cutoff age? For example, this 5-year-old that we had, was it appropriate? And yeah. And also the others wanted to know with ceftriaxone, we have said that ceftriaxone is our first line. They want to know, are there any other first line medication given the ceftriaxone resistance patterns that we see? Is there any other option that they can easily go to in case of the ceftriaxone resistance patterns?
Okay, so the first one is about?
First one is about when Busingye, the time.
So we can do, so we can do Busingye for children and for infants and children. So you can do it among all the children. However, like I said, in the younger ones, it may not be present. I mean, the signs may be negative, but that may not necessarily mean much to you. However, you may also find it positive. So again, I'm not saying that just because you may not see it, don't do it. However, I'm saying that a negative sign does not necessarily mean that you're on the wrong track. Yeah, then
the resistance to ceftriaxone.
yes, so the guidelines currently recommend IV ceftriaxone at a meningitis dose. You may also have an alternative of using IV cefotaxime, especially for the younger children, and most importantly, for the neonates. We may also use amikacin in addition to ceftriaxone. So having ceftriaxone and amikacin together to increase really, especially the coverage for the gram-positive bacteria. However, as you start these treatments, like I said, we need to continue the investigations. So as cultures return, CSF culture, blood culture, this will also guide your additional antibiotics. If you have other suspicions, for example, if the child maybe had an abscess somewhere and you're thinking that it's probably Staphylococcus, you may use other antibiotics like vancomycin, which especially covers for the methicillin-resistant Staph aureus. However, generally speaking, our guidelines recommend first that you begin with the IV ceftriaxone as you continue to investigate and find what the actual cause might be in this child.
Okay, thank you so much, Dr. Juliana. I think that is where we shall stop with the questions for this particular session. We have noted that the choice of the antibiotics is going to be directed by the cultures that we are doing for these patients. And as a country, we have decided that ceftriaxone is our first line, and we have been shown how we can change and when we can bring in which drug. So we shall move into the next part of our session. We shall listen in from a case presentation from Dr. Olympia Tombe. I hope you are ready, Dr. Olympia. Can you hear us? Dr. Olympia is online.
Yes. Hi,
Yes.
I can hear you.
Hey.
Just trying to share my screen.
Good.
Hello? Hello? Sorry, I lost audio now. Hello? Can anyone hear me?
Dr. Olympia, we can hear you.
Okay. And can you see my screen as well?
We cannot see the slides yet. Are you trying to share them?
Yes, yes, I am. Okay, how about now? Hello?
The team
Hello?
here will share your slides for you. You have just put them up. Can you see them?
Yes, yes, I can.
So you
Okay,
shall
hello
follow.
again, everyone. Thanks for having me today. So, okay, no problem. So I'll be presenting on meningitis in adults, specifically the AME approach. Next slide, please. So this is Miss R.O. She's a 32-year-old female brought in by ambulance in a semi-conscious state post-collapse. Collapse history from the brother revealed a headache for the past 2 weeks. Next slide, please. Okay, so in our approach, we use our standard ABC approach. So for airway and C-spine, airway was noted to be patent. There was no need for intervention there. On breathing, she had normal respirations of 11, but was desaturating at 90% on room air, and SATs picked up to 98% on oxygen. We noted a productive cough and some crepitations in the left lower zone. So we continued oxygen by a simple face
Tombe,
mask.
could you
Then we
please
did
a little louder? The participants can't get us so well.
Okay, sorry, how about now?
I think that's more clear. Thank you.
Okay, great. So, so just starting from our airway and C-spine, airway was known to be patent. On breathing, she had normal respirations of 11. She was desaturating at 90% and picked up to 98% on oxygen. We also noted a productive cough and crepitations in the left lower zone. So we continued our oxygen via a simple face mask, and head of the bed was tilted at 45 degrees. On C, she had normal BP and pulse rate. Capillary fill was 2 seconds and noted to have hot extremities.
Excuse me, she's still quite soft.
Hello? Okay, I'll try to speak louder. I hope this is better.
Look,
She was
the history.
Okay, she was also noted to have one large bore IV cannula in the left cubital fossa. So we inserted a second large bore on the right cubital fossa and collected blood samples for our baselines, including lactate and HIV test and the blood culture. We also started her on 1 liter of ringless lactate. On disability, she had an RBS of 7.9. She was altered with a GCS of 8. Left pupil was also noted to be dilated at 5 millimeters and unreactive. The right pupil was 3 millimeters and reactive, and the neck was supple. On exposure, there was no obvious trauma noted, and she was febrile. At this point, we gave her paracetamol and started on ceftriaxone and metronidazole. Next slide, please. In terms of the sample history, so as mentioned, this is collateral history from the brother. So what we gathered was that the headache had been there for about 2 weeks with associated weakness. At some point, she was reportedly unable to walk and talk. There was no known history of trauma, no known seizure history, and her pregnancy and HIV status was unknown. Allergies and medications at the time were also unknown. On past medical history, she had previously been to the clinic for the said complaints with minimal improvement. However, interventions at the clinic were unknown at the time. And she also has no known chronic illnesses. Last meal as well was unknown. In terms of events surrounding the collapse, she apparently had some dizziness prior to the collapse and soon after was unable to walk and talk. And again, no seizures were reported. Next slide, please. So in terms of the problem list, we had 2 main issues we had to address. So the first was altered mental state. We had to rule out intracerebral hemorrhage, a possible space-occupying lesion, meningitis, and electrolyte imbalance. The next thing was the hypothermia and hypoxia, which was suggestive of possible sepsis, and we aimed to rule out brain abscess and pneumonia. Next slide, please. So her investigations came up. So on full blood count, she had a normal white blood cell count of 4.1. Normal HB was slightly reduced at 10.3 and had thrombocytopenia of 42. On the renal function and CMP, the main thing was a mild hypokalemia of 3.1. The rest of the parameters were normal. For the LFTs, they were generally normal, just a mild elevation of the direct bilirubin at 4.1. Next slide. We also did a pregnancy test, which came back negative, and rapid HIV test also came back positive, along with a positive cryptococcal antigen. ECG was done, which was normal. CT brain was unremarkable, and then we proceeded to do the LP. Unfortunately, at the time, the chest X-ray was unavailable. Once the CT brain was noted to be unremarkable, she was started on meningitic doses of ceftriaxone, pending her LP results. Next slide, please. So CSF was noted to be slightly turbid. On the chemistry, the protein was elevated at 0.89 with a normal glucose. On the MCS, she had elevated WBCs of 110 and noted to have yeast cells, Cryptococcus neoformans, and there was no MTB detected on gene expert. Next slide, please. So diagnosis made was cryptococcal meningitis in a newly diagnosed HIV patient with suspected aspiration pneumonia. Next slide, please. So in terms of definitive treatment, this followed up. She was admitted to the medical ward and started on amphotericin B, flucytosine, fluconazole, diclofenac, ceftriaxone, and metronidazole. This was to cover for the cryptococcal meningitis and aspiration pneumonia as well. Next slide, please. And then supportive management, she had therapeutic LPs done following admission. They started on alternative days, but also done when they noted signs of increased intracranial pressure. She was also put on IV fluids at 3 liters in 24 hours with 1 liters ring of lactate and D5 dextrose 5%. She was also on oxygen PRN and under neuro observation. So any seizures or worsening GCS and headaches were the key things they were looking for. Next slide, please. So at the time of completing this was at the end of last week. She was still admitted in the medical ward, but she was noted to have improved slightly by day 8 of admission. GCS had improved to 10/15, and pupils were bilaterally equal and reactive to light. She is still currently on the same treatment. Okay, that's my presentation. Hello.
Hey, Dr. Tembo, thank you so much for that presentation. We shall have just 1 minute to hear the reactions to this case presentation. Some few questions for Dr. Tembo, and then we can move on to the discussion of adult meningitis management. Some of the questions that have already been asked to Dr. Tembo, she asked, Eric asked, why did we have a CT done, yet we had a GCS of 6, and also wondered what the random blood sugar was, which was 7.9, as Dr. Tembo had said initially. So Dr. Tembo, you can try to answer that question. Why did we have a CT scan done with a GCS of 8? Eric would like to know.
Okay, so in this case, the patient's history was a bit unclear. Remember, she came in with a history of collapse followed by inability to talk and speak, so basically altered mental status. She also had anisocoria, a blown pupil, so we had to make sure that she didn't have any space-occupying lesion or any intracerebral hemorrhage, because those would be contraindications to the LP. So at this point, meningitis was on top of our list.
Okay, thank you. The other question is why in the drug management did we add ceftriaxone if we had a positive CRAG and a relatively normal white blood cell count?
Right. So you have to remember that this was approaching the A&E. These results don't come back as quickly as we need them, but we have to act based on the presentation and the clinical picture. She had a fever. She had bounding pulses. Also, she had reduced entry on the left side. So we're also suspecting that there's a possible sepsis. So even though we didn't have the results back, it was beneficial to start antibiotics for her. So that's why we started that. And then when the results come back, that's when we adjust our treatment accordingly.
Okay, thank you so much. I think we shall move on to the next part of our session where we discuss the emergency approach of meningitis in the adults. I see some people asking for tericin, flucytosine, fluconazole, isn't that a bit too much? I think the next session will help us try to understand better how we can best approach these patients. You're welcome, Dr. Enoch.
Yeah, thank you very much. I don't know whether you can hear me. Can you hear me? Okay. So I'll proceed with a presentation of the emergency approach to adult meningitis. As you well know, with the vaccinations that took place earlier on, we had a meningitis belt as presented earlier, and most of the meningitis in adult by then was bacterial meningitis. But with the vaccinations that came in, the trivalents and the pentavalents, and also with our overuse of over-the-counter antibiotics, this has led to a drastic decline in real bacterial meningitis in adults. And as you go on, you'll see that most of the meningitis in adults is actually not bacterial, it's more of either fungal or TB meningitis, which is a slight shift from the children, as you have heard from the presentation. So when you go to the adult wards, you realize that actually 60 to 80% of this meningitis in adults is actually HIV associated. And about 60% is really caused by CM, which is cryptococcal meningitis. And about 6 to 17% is by TB meningitis. So you'll find that actually bacterial meningitis can be around 2 to 4%, and others are caused by viral, which sometimes cause a meningoencephalitis. So you realize most of the meningitis in adults actually require some sort of lumbar puncture to really have a conclusive diagnosis, and a CSF sample will be very beneficial in making the diagnosis. So by the fact that most of the meningitis is HIV associated, it's also very important to understand what is advanced HIV disease, especially in adults. So advanced HIV disease, according to our current guidelines, is if a patient presents with a CD4 of less than 200, or a patient who comes in when it's newly diagnosed and is ART naive. Generally, you categorize those patients as advanced HIV disease, or if when they present with a stage 3 or stage 4 disease, which is categorized in our WHO diseases as stage 3 or stage 4, then you categorize those as advanced HIV disease. So the reason why this comes into play, because we have also patients who come in when they have been on ART. Sorry. Yeah, there are patients who come in when they have been on ART, but then they are failing on their ART and are presenting with such diseases. So we still have to screen them for this advanced HIV disease. So I'll present one of the main causes of adult meningitis, is cryptococcal meningitis, and how it presents. So generally, cryptococcal disease or cryptococcal meningitis is caused by Cryptococcus neoformans. Cryptococcus neoformans usually spores are present in the environment, and some theories have suggested that some of these spores are actually inhaled at birth. So they be in our bodies since we are born, and they are generally in a latent state. However, when there is some sort of immunocompromise to our body, these spores become active again, and they have a high stimulus to go to the brain because of the good blood supply there, and also a lot of nutrients. So the most common areas where Cryptococcus goes is the brain. However, it can also go to other areas, as we will see. Sometimes it can cause Cryptococcus skin disease or also pulmonary cryptococcosis. Next slide. So when you look at this map here, you realize that Uganda is part of the countries which also have a high burden of cryptococcal disease. I think secondary to South Africa and Nigeria, as you can see. So if you go to the ID wards in most of the facilities in Uganda, you realize that the disease is really very prevalent, and it's one of the most common meningitis in adults. Next slide. I'll not go much into the manifestations of this disease because generally most of them are similar, slightly similar to children, whereby most of them will present with meningismus, which is neck stiffness or sometimes a positive panic, and that is generally due to inflammation of the meninges. However, the most common symptom that these patients present with is generally a headache. So some of them might come to hospital without any other symptom, but just having a headache. And when you check them and realize that for some reason they're somehow immunocompromised, which might be either due to HIV or some other sort of immunocompromise, like our presenter suggests, like cancers, or some of them were on steroids, or it's some sort of other immunocompromise. It's very important that you screen these patients for cryptococcal disease. So sometimes when they present with an encephalitis, this one usually gives them some sort of confusion besides the meningitis. So they'll present very, very confused. And sometimes when the pressures are very high, it's one of the meningitis that presents with really very, very high pressures in the brain and gives them very, very high intracranial pressures. And these patients will present with other symptoms which involve projectile vomiting, photophobia when they look into the light, and also sometimes it gives them papilla edema, so they sometimes lose sight, can cause inflammation of the some of the nerves that traverse the brain, especially at the base of the brain. So it can give them some cranial nerve palsies, especially cranial nerve 6 palsy, and sometimes it can as well give them some hearing impairment. Next slide. Next slide. So when you look at this slide, this can be also another clue that this person might be having cryptococcal disease. Sometimes this cryptococcal skin disease can present like this with some bit of raised kind of purpuric rash, but sometimes they're implicated and somehow they look like molluscum. However, the ones for cryptococcal skin disease are usually bigger. So when you look at this kind of disease, you suspect that this person might as well be having cryptococcal disease. But also at another point, at emergency wards, some of the patients can present with cryptococcal pneumonia when they have very, very disseminated cryptococcal disease. Some of it can really cause very bad pneumonias in the lungs. And when some of these patients present with some difficulty in breathing at emergency, you might think they're having maybe some aspiration pneumonia or so, like just like in our case presentation. And some of it can sometimes be cryptococcal pneumonias. And we have also seen cases of these patients whereby you treat them for cryptococcal disease and generally their chest improves without even pushing in some antibiotics. So these are some of the symptoms that I've been telling you that these patients can present with, generally headache, and also fevers. So these patients sometimes present with fevers, and because cryptococcal disease has been confused with a number of diseases in advanced HIV, sometimes cryptococcus presents exactly like TB. And we have seen also a number of patients being initiated on anti-TBs when they are not supposed to be initiated, because cryptococcal disease can still give you a high-grade fever, it can still give you a weight loss, it can give you sweats. So when they present with fever, it means they have a lot of cryptococcus in their blood. So it's good to first investigate these patients before we treat them for other diseases. And I already talked about neck stiffness, sensitivity to light, and also the nausea. So sometimes when you're in other facilities, if there is an ophthalmoscope, you can also do fundoscopy and look at the retina. You will see papilledema, as you can see in the right-hand corner here, whereby the optic disc becomes hazy and you can't see its original margins very well. It's a feature suggestive of really papilledema and very, very increased ICP. And these are patients who really need urgent lumbar punctures. So just like in our case presentation, when these patients present, there's so many other differential diagnoses that can be really thought about, because this disease can present like any other disease. Like I told you, it can present like TB meningitis, it can present like cerebral malaria, a meningoencephalitis, because it can give you a meningoencephalitis, which can be caused by so many other infections. And as well, it can present like other specifying lesions, like lymphomas, toxo, or abscesses, because sometimes it gives you masses, especially the cryptococcomas, which are very common in patients who are having better immunity, or sometimes are having second episode of the cryptococcus disease. And also sometimes it can be just presenting like patients who are having HIV encephalopathy with psychosis. So this cryptococcal disease or cryptococcal meningitis, generally the lumbar puncture parameters might not be as beneficial in diagnosing cryptococcal disease, because then we have a highly sensitive test which is available. So when you do a lumbar puncture and you get CSF glucose, CSF cells, and other parameters, they might not be as informative or diagnostic for cryptococcal disease. However, they can also help you to somehow guide you on the prognosis of the patient. For example, if a patient has a very high white cell count, it means there is really a lot of inflammation going on. If they have very low glucose, then it means the blood circulation to the brain is not so good. Maybe it could be a complication of the ICP, and somehow these are patients who need aggressive management. But however, the parameters as per se, they can be on either side of it. They can be low or high, and therefore they are not really so diagnostic. So that brings us to the next slide. This CRAG LFA kit, which I think it should be available in most of the emergency settings in our country, because this test is really highly sensitive and highly specific. And it's very, very important in diagnosing the first episode of cryptococcal meningitis. When you see these two lines with the test and the control appearing, means the patient is really having cryptococcal meningitis. However, when you see one line when you do the dip in the CSF, then it means that person is not really having cryptococcal disease or meningitis. However, a caveat to this is sometimes it can also give you a false positive or a false negative, but mostly false negatives are the most common ones, because it is prone to having what they call prozoning effect, especially if someone has a high burden of antigens in their blood. Sometimes it can give you a false negative, yet the person has high burdens of cryptococcal disease. And in such scenarios, that's why you send a sample for possible dilution, or using other higher test kits which can do higher titers. But otherwise, it's very sensitive for first episode. However, in the upper right-hand corner, you can see culture, which remains the gold standard. The reason why culture is still the gold standard, it's because the CRAG LFA is good at first episode of the CM. However, it may not be good at distinguishing whether a person has a relapse or a second episode of CM, because it remains positive for quite a long period of time. And the most standard is to really send this sample for culture to see whether the Cryptococcus grows or not. So culture remains the gold standard, and it also helps us to quantify how much of the fungus this patient might be having. The one below here is the India ink, which is currently being faded away because of its low sensitivity, reaching up to like 60–70%, and might high chances of missing even the Cryptococcus. So it's being faded away. But however, if you don't have any of these two, then you can still use the India ink. It's also very easy to perform in the lab. Generally, that's cryptococcal meningitis, not so much in details, but the main thing is to really diagnose the disease and also put the patient on effective treatment. I can say the mortality of cryptococcal meningitis is now ranging between 35 to 40% in still our patients, even with good antifungals. So which means that earlier detection of these patients is very, very key in reducing their mortality. And the treatment for cryptococcal meningitis is really divided into 3 phases. The induction phase, the consolidation, and the maintenance phase. However, the induction phase is the most important because that's the phase where we want to rapidly clear the fungus, because most of the mortality that occurs in these patients occurs in the first 2 weeks when this disease is diagnosed. So it is the most important phase. Then we have the consolidation phase, which goes up to 8 weeks, where we have to put these patients on high dose fluconazole, but however at a slightly reduced dose, and they have to take it for 8 weeks. However, maintenance phase is also very important because these patients, they have to be put on prophylactic fluconazole until their CD4 count is somehow raised above 200, or maybe their virus is somehow suppressed. Otherwise, if they don't go on maintenance fluconazole, or they prematurely end it early, where we recommend at least 18 months, then they have a high chance of coming back with relapse of the disease. So there is a trial which is recently completed, the Ambition trial, which led to the change in the guidelines. Change in guidelines. Previously, we had amphotericin B deoxycholate, and as we saw in our case presentation, our patient received amphotericin B. It was not so clear whether it was the liposomal amphotericin B or the amphotericin B deoxycholate. However, as you well know that amphotericin B is really a very, very toxic drug. It can cause renal toxicity, it can cause severe phlebitis, and sometimes it can cause also alcohol. So, yeah, as we give these patients treatment, we have to consider our toxicity is very, very important because they have also contributed to mortality in our patients. And as in the previous case, if a patient received amphotericin B deoxycholate, and I realized also in one of the treatments they gave NSAIDs, that can worsen the injury to the kidneys and it causes much worse. So there is a recent completed trial, which is Ambition, that brought into action the single dose liposomal amphotericin B, which is now given to patients, next slide, given to patients as a single dose on the first day, and then they just continue with the oral antifungals, that is the flucytosine and fluconazole for 14 days. However, in scenarios where I don't have the liposomal amphotericin B, we still use the amphotericin B deoxycholate, which needs routine monitoring because it's slightly less lipophilic and more renotoxic. Next slide. So yeah, still at emergency, also we have to know about the flucytosine, which needs four doses in a day. That is 6 hourly dosing, and it's also somehow a little bit toxic, which needs monitoring with a CBC because it can cause thrombocytopenia, and also it can cause a lowering of some of the CBC parameters, and therefore needs some monitoring. So our people at emergency also need to know about that. And I talked about the renotoxicity, whereby these patients might need readjustments either in their aflatoxin or also in adjustments in their amphotericin doses, and also to avoid using nephrotoxic drugs like NSAIDs, which add to the injury to the kidneys. So sometimes, next slide, sometimes these doses have to be, next slide, they have to be really adjusted to account for this. And you know that most of the patients come in when they're immunocompromised, and some of them, they really have already deranged parameters. Can skip. Next slide. One of the other important, one of the most other important thing is managing really intracranial pressure for these patients. And you know that when these patients present with raised ICP, sometimes they present with Cushing's triad, whereby they have a bradycardia, increased respiratory rate, and also sometimes their blood pressures go up. And I have seen also in most of the scenarios where patients are given very fast antihypertensives at emergency when they are not supposed to be given antihypertensives, when the actual cause is actually the Cushing's triad. So one of the key important aspects that we have to really do as emergency doctors when we receive these patients is not to hurry to start them on antihypertensives, because that will shut their blood supply to the brain, and then the disease worsen. So we have to manage their pressures very, very importantly. And as you can see here in the guidelines, most of the guidelines recommend that if pressures are above 250 millimeters of water or above 25 centimeters of water, these patients have to really receive daily lumbar punctures until their pressures are lower. That is in place if they don't have contraindications to lumbar punctures, which you will read about. And also in scenarios where we don't have manometers, like most of the settings we have, and also in emergency settings, sometimes you might not have a manometer. At least you try to take off an amount that can try to reduce the opening pressure of these patients. And most studies have come to somehow a conclusive volume of about 10 mils to be able to at least reduce the opening pressures when you really don't have a manometer. But however, also other studies have suggested use of counting the drop rate of CSF when you're doing the LP. If the drop rate is really rapid, you will know that that is very high opening pressures, and that will trigger you to take off some large volume and also to try and repeat another LP the following day. Also, to put in note that the current WHO guidelines nowadays, they no longer emphasize opening pressures. Some patients can actually present with very high opening pressures without having symptoms. And some of them also can be having normal opening pressures, but then they tend to have a high fungal burden. So these days, it doesn't matter what the opening pressure is, these patients necessarily need to have another repeat lumbar puncture. So we don't stop on the day one lumbar puncture. You have to get more therapeutic lumbar punctures to ensure that they have a better prognosis. Next slide. So then comes in the conundrum of really managing their art. It's really a very big thing, and also it's dependent on where and which country you're based in and which guidelines they use there. But that is a brief summary that you can use to really try and juggle with the patient's art, because some of them will come when they're not adhering, some of them will come when they have been off art, some of them when they have just initiated. But however, I'll not go much into the details of that, but maybe you'll read through the slides and have a detailed. I don't know how much time I have, but maybe next slide. Let me just juggle through TB meningitis, which is really another very, very important disease. And it's also very common in our adult patients. And it's highly more fatal than crypto, though the prevalence is slightly less. So yeah, generally TBM is the most severe form of TB, as you all know. And the mortality is really high. It can reach up to 70% in HIV patients. And this is a disease which also can affect patients who are very, very immunocompetent. And also mortality there is very high because then they induce a lot of inflammation. When you look at the image there, you can see how much TB can do. It can give you this, if you can look at the picture in the left upper hand corner, where all the meninges are very inflamed with a lot of hyperemia. So it can give you very bad meningitis. It might not give you a severe headache as that of cryptococcal meningitis. So usually these patients will come in with moderate headache or even sometimes no headache, but with very, very bad neck stiffness. So that should stimulate you to think of meningitis. Also, when you look at the second image on the right upper hand corner, TB meningitis can give you a stroke. So I have also seen very many patients who come in, present at emergency with a stroke and very high BPs, and these patients are taken to be having hemorrhagic strokes or hypertensive strokes when they're actually having TB meningitis. So this is one other thing that, of course, emergency doctors need to know, that TB can give you very, very bad strokes. The other one here is, if you can look at the, that's the left lower corner, this is an autopsy of the brain that had a tuberculoma, very big tuberculoma, as you can see there, with infected areas. So TB can give you a very big tuberculomas that can give you focalities and stuff. But also we have seen patients who present with very, very bad hydrocephalus, just hydrocephalus alone. You do the CT scan and you see that all the ventricles are enlarged when the patients are generally stable. Sometimes it's a trigger to that. So yeah, sorry. Okay, yeah, I have 2 minutes to summarize this. So next slide. So unlike cryptococcal meningitis, TB meningitis diagnosis is very, very complicated, and sometimes it's very, very often missed out. Most of the patients we receive at emergency, you will find that they have been in clinics, and also some of the big hospitals where they have been managed for cerebral malaria, for other causes of encephalopathy, without really coming to the diagnosis of TB. So TB diagnosis requires a good clinical history. You have to do some radiology investigations, because some of the tests we have, like the urine lumps, the expectorant trust, still miss a lot of TB, and they might be negative even when the patient has TB. So you have to do at least a lumbar puncture to look at the CSF parameters. Like I told you, in crypto, CSF parameters might not be that important. However, in TBM, CSF parameters are very important, especially very low CSF glucose, less than 2.2 millimoles is really diagnostic for TB in a patient whom you're suspecting. A high CSF lactate above 3.5 is really diagnostic. Sometimes the CSF color, patients who have TB usually presents with some benzachromic CSF, which is slightly yellow color and stuff. So yeah. And treatment is really varied. Just like you had in children, steroids might not be important, but however, in adults, actually, TB meningitis, steroids are very important. The study was concluded. Yes. Okay. Yeah, in adults, steroids are very, very important in TB. And however, in HIV patients with TBM, it's still being studied. It's still unclear whether steroids are very important or not, so that will be dependent on case-by-case basis. However, in HIV negative, steroids are very important. Also, you might need to add in other drugs like aspirin, anti-seizure, because these patients present with a lot of comorbidities, anticoagulants when they are really very bedridden because they can get very bad strokes, PPIs or antacids, and also they need a lot of physio. Yeah, generally that's what I had for you. It's fine. Yeah, that's what I had for you for adult meningitis. The bacterial meningitis, the management is generally similar to children, and it's less common in adults since it was already presented on in children. I will not go further. Thank you very much.
Okay, thank you so much, Dr. Enoch Kajimo. That was a very elaborate explanation of CCM and tuberculosis meningitis, but also on that last point of bacterial meningitis. Most of the questions have actually been answered by Professor online. Professor, thank you so much for following up on the chat and answering some of our participants. But I think just one question that I think has not been hinted upon is still steroids. We have seen the use in tuberculosis, but people would like to know in terms of Haemophilus influenza meningitis, the bacterial kind, they seem to say that that is helpful to use in that particular causative agent. We would like to hear what your comments are. Then we can move on to the nursing care of the meningitis patient. Haemophilus influenza. They would want to know how helpful, because we mentioned earlier that there is no clinical benefit of steroids in most of the bacterial, most of the bacterial meningitis causes, but for specifically Haemophilus influenza, they would like to know, is it still also like the rest of the bacteria or not?
Yeah, for Haemophilus influenza, it's also still very, very unclear whether it has some benefit. Some studies have found it very beneficial, especially when you give it at a lower dose without giving it for a longer period of time. They have suggested that it can be of benefit in some scenarios. However, it's still inconclusive whether they are still very beneficial in most of all the bacterial meningitis. Yeah.
Okay, so the evidence is really not very clear.
Yeah, not so clear. Okay. Some say if give it for a shorter period of time and then stop, can be very beneficial, or a lower dose.
Okay, thank you very much. As Miss Olive Carroll sets up, I would invite Professor Meya to just give us some comments or some insights into adult meningitis. Professor, you're welcome.
Okay, thank you. And as people sort of wind up, I know that Enoch and our pediatrician have covered quite a bit just in terms of meningitis. You know, we continue to see meningitis, whether that's in children or adults. And I think the biggest challenges seem to be in adults. There's been much better performance in terms of pediatrics to prevent, pneumococcal meningitis. And I don't have the figures, but I know that pneumonias definitely are much less because of the vaccination programs. Adults, we obviously continue to see mostly HIV-related meningitis. And the cryptococcal meningitis, sort of straightforward to diagnose. TB meningitis, I think, is problematic, but certainly the expert ultra, I think, has provided the opportunity to, to be able to diagnose patients with TBM. And then, of course, you have to add the other biomarkers as well, CSF glucose. The newer TB diagnostics, which are, I think there's research going on to try and figure out whether they would have much better sensitivity. But most of the time, TBM tends to be more of a clinical diagnosis, especially in the absence of the expert ultra. The other types of meningitis caused by viruses are much harder to figure out. And if you notice, I'm not talking very much about bacterial meningitis in adults, especially because we've only seen, and that's over a period of close to 2 decades. There's only about, 1 to 3% of adults who present with bacterial meningitis. So that's, if somebody shows up, particularly an adult, if they show up and they have meningitis, be more concerned about cryptococcal and TB meningitis. Those are the ones you have to try and make sure you exclude. Of course, everybody gets started on ceftriaxone, and I think I noted in the chart that I don't think that's a drug we should be using in our public healthcare system. I think cefotaxime might be a much better alternative now because the resistance to ceftriaxone is obviously, it's crept up, I think, to more than the WHO recommended 35% resistance, where you should be changing the drug. So that's still a huge problem. And I hopefully at some point it's a drug we will switch to. Mortality continues to be a big problem, particularly in TB meningitis. I think over the years, cryptococcal meningitis diagnostics and combination treatment regimens have reduced mortality. I think Dr. Kajimu noted the oral amphotericin trial. Did you? I think you did. That highlighted, that's one of the best survival rates we have ever seen in cryptococcal meningitis, 10% mortality. Now, unfortunately, I don't know whether the drug will ever go commercial. The company didn't have money to move it forward. But if they did, maybe that would be a really good option to use as well, because those patients were on the oral amphotericin for a much longer period of time. So yeah, there are new compounds on the horizon. There are some super azole compounds that hang around with a T half-life of almost 3-4 months. So it's possible that down the road, people might be treated with oral amphotericin or and continue with azole compounds that they don't have to take every day, maybe once or twice a month. So thank you for organizing the session. I think, and just to note, I have never been on a webinar where there are 400 people. So excellent job.
Thank you so much, Prof. And thank you so much for answering many of our online chats. So we shall move on to the nursing care as we put up the slides, but also most of us are asking about the CPD link. It will continue to be shared. Maybe some of you missed it, but it had already been shared. And also asking about the slides. The slides for the pediatrician and from Dr. Enoch will be shared with us. So please let us move on to the next part of the session. Ms. Kayo, welcome.
Good afternoon, everyone. I'm happy to be here to present the nursing care from meningitis in children and adults as well. Like the previous presenters, we know meningitis is an inflammation of the covering of the brain and the spinal cord. That's the meninges. And it's trying to increase the font. It's one of the commonest cause of meningitis infections in adults, especially the Cryptococcus neoformans, and which causes cryptococcal meningitis. The etiology of the meningitis, we are looking at the different organisms that are causing the different kinds of meningitis. Basically, the bacterial, we are looking at Neisseria meningococcus, and we are looking at also Streptococcus pneumoniae and Mycobacterium tuberculosis, which causes TBM. Those are some of the common causative organisms in both children and also in adults. And also the fungus, there are also, we have the Cryptococcus neoformans, we have Aspergillosis, those are fungal. The Aspergillus causes Aspergillosis disease, and then the Cryptococcus neoformans causes the cryptococcal meningitis. Then the viral, we are looking at the mumps, hepatitis simplex, and others. However, the data about that is a bit scanty. It's not readily available. And also we are looking at the parasitic, which is caused by schistosoma. Then next, we are looking at the epidemiology in adults. In adults, we know that the prevalence of meningitis in adults, all the different causes of meningitis in Uganda is close to 60%, and the death rate is at that percentage, and also one of the commonest cause of meningitis in adults, like we said, is that emergency nursing care will skip the presentation of the patient. We presume they are the same signs and symptoms. The nursing care of these children it will depend on how the baby or the child presents, because we are looking at these children, or either mostly who are being affected with the infection of meningitis are below 5 years, and also the neonates. So we are looking at how our patient presents, and this will guide us on how we will manage these patients. So these patients, assuming this baby is having signs and symptoms of meningitis, as a nurse, you need to put on your PPEs, you call for help because this is an emergency, and you need to act quick as a nurse. You triage the patient using the approach of ABCDE approach, and in this case, this is helping us to prioritize care accordingly. So you look at this patient, what are they presenting with? Are they having seizures? If they're having seizures, you look at beginning with A, is the airway okay? Because when someone is seizuring, the tongue can fall back, and it blocks the airway. So look at the baby, is the airway clear? If it's not clear, you do the needful, you insert the airway to open the airway. Then B, you're looking at the breath. Is the breathing of this baby or this child okay? Then you look at the saturation, you check the thing of the child to see the peripheral activity, how it reacts. Then we are looking at the disability and then the exposure. Then just in case this patient has seizures, has a temperature, then if they are seizuring, they have a temperature, you open the baby, you undress them to expose them to fresh air, and then the temperature is very high. You need to do tepid sponging, and in that way you have to use lukewarm water when we are doing tepid sponging. Meanwhile, you have to also act on the seizures. Remember, the seizures are very deadly. You have either to administer the Valium. Remember, this is a collective action. You've communicated for help. Then either the doctor will recommend Valium to be administered to this patient in order to reduce on the seizures. And then we are looking at the high temperature. You've done tepid sponging, it's not coming down. Then you may put up the IV paracetamol, And also you have to examine or assess the state of the body, the baby. How is this baby? Are they also dehydrated? So that you also have to run some fluids. And these fluids are important that you run them carefully, because as you assess, you have to be sure that there are no underlying problems of edema, so that not to cause further problems. So we also have to ensure that the important vitals are done, pulse, which you have to check for the SpO2, or how is the patient saturating. If they are desaturating, then you have to administer oxygen. If they are saturating well, then there is no need. And then you also have to check their BP. If they are hypotensive, then the fluids are very much recommended in order to raise the BP. And also, if already the temperature is high, and also now you have to follow your rapid assessment, still like using the AVPU approach, and that is you're looking at you're assessing for the patient. You're assessing for the patient's alertness. Is the patient alert? You're assessing for verbal response. Is this baby, can they respond to any to any stimulus? Is the baby in severe pain, or is the patient unresponsive? I needed to have told you that as you're assessing, you need to be sure that the person you're trying to work upon is really alive anyway, because you can't begin working all those and the patient maybe is no more. So as you work that, you're observing the patient is breathing, is well, in their good state. You're doing the emergency nursing care in order to help the patient get back. Amidst that, as we are assessing, we want to categorize our care and also prioritize our management. So in this way, we want to find out what's the state of this baby. Is this child to be categorized under the red zone? The red zone, these are the babies that really need emergency help, like I've said, and those that are assuming during the time of triage, the parameters are okay, the patient is fair, probably they'll be categorized under the yellow zone. Those need close monitoring, and those the green zone, those babies are stable, like you've worked on them and they've stabilized, they can wait in the queue for further management. So you focus on the emergency. And then we are, like I said, we've looked at our patients, necessitate whatever they need at that particular time, you handle as an emergency. Can you move on? Slides. Then we also look at nutrition assessment. You assess these children, because for the nutrition assessment will depend for those patients who are 3 months and above. When you perform the MWACA, it will be 13.5 less. If it's less than 13.5, that means this patient is malnourished. And if the babies or those children are below 3 months, you perform the MWACA and you find out that it's 11.5 centimeters. That is also an indication that the baby is malnourished. So in this case, you handle them accordingly, nutritional care and counseling. However, after the emergency handling and all that. If this patient stabilizes and because they are severely malnourished, they will necessitate to be also referred to the respective places, that is the Namuju unit. Can we move on? We are also looking at the different investigations. Those investigations will guide us on the appropriate way of managing this patient. Remember, we are in an era of microbial stewardship where we as health workers, we have to also join the fight against misuse and misuse of antibiotics. So we don't just administer antibiotics anyhow. So it's important to carry out certain investigations, especially the culture investigations that will guide the clinician what rightful treatment or medication that is fit for the patient, those that are sensitive and those that are not sensitive, or those are resistant to those particular organisms. So that will be rightful to be done. And also we would want to perform the CBC, the RFT, the LFTs. All this will help us in our management in order to not to mismanage the patient, but to ensure that certain complications are curbed beforehand, like electrolyte imbalances, hepatotoxicities, and all that. Can we have a we are looking, can we go to the next slide? At least those are already there. Yes, we are looking at management of meningitis in adults, and looking at like already it's been explained the different kinds of meningitis. My presentation of this adult management is tailored to the case presentation of a patient who had meningitis, and for that reason, we have our nursing goals. Just the next before, and just briefly before. Yes, we are looking at our goals. We want to prevent post-lumbar, assuming this patient is confirmed, is having cryptococcal meningitis. We want to prevent post-lumbar headaches as our goal as a nurse. Yeah, we have to clear the causative organism. We want to prevent complications. We want to prevent electrolyte imbalance. We want to prevent drug-induced toxicities. The next. And in our nursing interventions, remember, this is an emergency. You handle, it will be handled as the previous. You assess this patient, which state have they presented with? Are they seizuring, or are they running a high temperature? Are they confused? Are they fighting and all that? So you manage the patient accordingly. So in this sense, assuming in our position, because we want to, we're assuming this patient has been worked on and has stabilized. They've been confirmed to be having cryptococcal meningitis. So we would want to prevent post-lumbar headaches by positioning them in the right way, in the right posture in the bed, that is lying straight still. I mean, lying flat. And also we would want also to have proper and safe administration of the drug, as we are going to see in the other slides. That is the new current drug that is high-dose liposomal B, flucytosine and fluconazole, and how the liposomal is prepared and it's reconstituted. Then we also want to have a proper management of complications. We want our patients, in case they happen to have phlebitis. Can we manage phlebitis? How is phlebitis managed? One maybe to bring you to speed, phlebitis. This is the swelling at the cannulation site, the cannulation site of the patient, and this could be either due to infection or due to infection, and we want to prevent further problems by either changing the cannula, and also the clinicians will also do culture taste in order to know what antibiotic to help the patient with, because these phlebitis come with high temperatures in those patients. And also we would like to prevent electrolyte imbalance by supplementing the electrolyte supplements, that is the mag, and also the slow magnesium, and also potassium and IV potassium as well. Then we will also want to do the management, administration of the liposomal amphotericin drug as well.
Thank you so much, sister, for that elaborate nursing management in the emergency department. We are very, very grateful to all our panelists for the time you've given us, and also to the participants. We have gone 20 minutes into the aforementioned time that we should have stopped at 4. It's now 4:20, so we have come to the end of our session. We would like to thank you, our dear panelists, for the knowledge, and all our presenters, Dr. Geofrey from Mulago. Thank you so much. At this point, I would like to call upon our panelists, starting with Dr. Geofrey. Is there any closing remarks you want our participants to go home with?
Well, thank you very much. I believe as healthcare practitioner, we can reduce the complication that comes by adequate history-taking examination and making a prompt and early diagnosis and initiating early treatment to prevent the complication that can come from meningitis. Thank you very much.
Thank you very much. I think we also have the post test that has been posted. I hope you can see it as we continue with the closing remarks. Dr. Elo.
Yeah, thank you very much for inviting us to present on meningitis. My closing remarks is that management of meningitis in adult is rapidly changing. We have to keep very, very updated with the new guidelines that come in and other knowledge. Then the other thing is that it's highly fatal if you visit the wards. So it needs sensitization of communities, health workers to really know that these diseases are highly fatal, but they can be treated and patients can be better. So that's what I can say. Yeah. Thank you.
Thank you very much. I think we shall have one remark about the nursing care on these patients, and as we come to close our session.
Thank you so much. My final remark is that managing these patients with meningitis is quite a challenge, and as nurses, we need to be vigilant. We need to be updated with the current information on how to manage the children and the adults with meningitis. Thank you so much.
Okay, thank you so much, Sister Carol. I will invite Dr. Tembo. Are you still on with us? Any closing remarks as we close? Dr. Tembo, are you there? If Dr. Tembo is not there, I will invite Professor Meya to give us the last closing remarks as we as we go through the post-test. Professor, you're welcome.
Thank you. I mean, I think I'd made my closing remarks, but just to really agree with what Dr. Kajimu is saying, I think it's the onus is on each of us as healthcare providers to, just make sure that we're up to speed with current guidelines. I think one might not be necessarily very close to the research that's going on, but I think it's through attending, CMEs like this that we're able to know what the current guidelines are. And there's, I think if you generally are not up to speed with the current guidelines, in some ways you are posing a danger to patients' lives because things do change fairly rapidly. And so it's important to keep up with the guidelines, and guidelines do change because we think that there's better modalities for treatment, there's better outcomes with new guidelines. So that's, I get concur that that's something that all of us should be up to speed with. Thank you.
Yes, thank you so much, Prof. The post-test is going on, and the pause, please submit an answer to help us improve how we better provide these sessions in the future. Please let us go to our pause and keep answering. Those asking about the CPD points, the link has been shared and will continue to be shared. And also those about the slides, we shall provide the slides that have been presented today. Thank you very much. Okay, as we answer the polls, are there any questions you would like our panelists to answer before they step out? Online, is there any questions that we may have skipped that you would like to draw attention of the panelists to?
Yeah, thank you, Jacob. This is Dickson Kamoga. I've been trying to answer some of the chat questions. However, there are some particular ones that I didn't have very precise answers to, and I don't think they were tackled during the discussion. So someone asked in the Q&A section whether it's routinely advised to give antibiotic prophylaxis for Neisseria meningitis, particularly in children. And if it is, then what are the guidelines recommending? Then there's also a question still in the Q&A section where someone asked whether there's a possibility of CCM occurring with a negative serum CRAG and what that is called. Then there's also another question of someone wanted the panelists to make a comment about the Odong Aginia stain, I think in the diagnosis of CCM. Then someone, this was answered, serial LPs. Then someone also asked the panelists to comment about the role of steroids in the management of Haemophilus influenzae meningitis specifically. Yeah, I guess those are the questions that I think were not tackled during the discussion.
Okay, I think starting with that last particular question of Haemophilus influenzae type B meningitis, we stated earlier that there is no evidence to actually support the use of steroids in that particular kind of meningitis. And even given the fact that in many times in the emergency department, you may not be able to tell apart what the organism that is causing that meningitis is. So to decide, and remember, they have given us a time window within which these steroids may be helpful. So in the emergency department, it's difficult to decide from your clinical history or clinical examination to say for sure that this is Haemophilus influenza type B meningitis cause. So what the panelists said that there is no particular evidence to support the use of steroids in this bacterial meningitis. I think they have asked a question about one of a test for cryptococcal meningitis. Maybe it's can pass this over to Dr. Enoch.
Yes, I think if I got the question well, it was asking someone having cryptococcal meningitis with a negative serum, correct, right?
Yes.
Yeah, I think that's what I talked about in the presentation. I think it was more faster. This test can give you a false negative on serum because it's because of a prozoning effect whereby if someone has a lot of antigens in blood, they can clog around each other and then they cover the positive antibody inside, and then the way they present it's like then it's a negative test when it's actually a positive test. So it's prozoning effect, and then so you can get a negative serum, and then you go ahead to do the lumbar puncture because the antigens in the CSF might not be as much as the ones in the blood. So they give you a positive test on CSF. So that person will be having generally a positive test in CSF and negative in serum, making you think it, but actually the disease in blood, because generally before the disease goes to the brain, it first circulates in blood and then it goes to the brain. Yeah.
Okay, thank you so much. How are the pause? Are we done with the pause? Okay, so it's time for the screenshots. Okay, so we have come to the end of our session. I don't know if there is any other burning issues, but thank you everyone for attending, being with us. We have taken extra 30 minutes of your time. But to our panelists, thank you very much for making time and being with us here. Coming from as far as you've come from your jobs. We may know some of you may be going back to shifts, but thank you for being with us and we are very grateful. And for all our participants for always attending these ECHO sessions, we are very grateful to you. And thank you. That is the end of our session. Thank you. And happy Easter. Happy Holy Week, yes. Happy Easter to you all. Okay. Thank you. Okay.